I'm George Nashak, President and CEO of Care for the Homeless, and it's my pleasure to welcome you this morning to another episode in our series of policy seminars regarding homelessness and healthcare. Care for the Homeless has a 35-year history of providing healthcare services to homeless and unstably housed people in New York City. We began this policy seminar series in 2019 as part of our public education efforts, attempting to prompt dialogue among service providers, academics, advocates, policymakers, journalists, and people with lived experience of homelessness to come up with ideas that impact the healthcare and the services received by people experiencing homelessness in New York City. We know, of course, that homelessness is linked with the occurrence of numerous acute health problems, and people experiencing homelessness very often suffer from multiple comorbid conditions, very often with co-occurring substance use or mental health issues. And in fact, people living on the street probably are exposed to more of these issues than even people in the shelter system. But there hasn't been a huge amount of discussion and debate about the way that healthcare services are provided to people living on the street. And so this is an attempt by Care for the Homeless to try to prompt that conversation, to see if we as practitioners can learn from one another in terms of how we can improve the healthcare and the behavioral healthcare of people living on the street, of course, with the eventual goal of trying to move them into permanent housing. Our goal this morning is to understand some of the most pressing health needs of unsheltered homeless New Yorkers, and how programs can be tailored to address those needs. We particularly are interested in the outreach and engagement that's essential to bringing people into healthcare relationships and working towards improving their health. We want to also look at how COVID-19 has affected the health of this population and how it's affected the way that we've delivered programs and services over the last 15 to 18 months. We also hope that this conversation will contribute to promoting recovery and bring more folks inside, because healthcare is great for people living on the street, but the next step, of course, or the co-occurring step, is to bring people into permanent housing as well. And I know that our panelists will have a lot to say on that topic. I'm delighted to introduce our moderator for this discussion, Dr. Andrea Littleton. Dr. Littleton is one of the outstanding physicians at Care for the Homeless, someone for whom I have an enormous amount of respect. She is also the medical director at BronxWorks, and so has a great deal of experience in working in the Bronx with people experiencing street homelessness. Dr. Littleton has been practicing family medicine for over 15 years at federally qualified health centers, including Care for the Homeless, Hudson River Healthcare. She also has experience working in hospital settings, particularly at Montefiore Medical Center. Dr. Littleton has been a champion for medication-assisted treatment, and in fact is one of the predominant dispensers of medication-assisted treatment at Care for the Homeless and at BronxWorks. She's also an assistant professor in family medicine and teaches and trains residents at Montefiore Hospital and the Einstein Medical School. We're very grateful to have Dr. Littleton with us this morning. I welcome you all as participants, and I welcome the panelists who Dr. Littleton will now introduce. Thank you very much.
Great, thank you so much, George, for that kind introduction. And it's my pleasure to be here in moderating this needed discussion. As George said, I have been doing this work for over 15 years, and I went into the residency program in social medicine because it was really important for me to treat the whole person and meet people where they're at, and certainly trying to provide care for patients on the street is truly that. It's been my joy to try to do this work, and I'm really looking forward to this discussion, to all of us figuring out how we can do it a little bit better. So with that, I will introduce our panelists. Our first panelist is Scott Atwater. Oh, actually, before we get started, I'm sorry, we were supposed to do a little poll. So if you could just take a minute to click on that, whether you're a healthcare provider or a homeless service provider. So I'll give you a minute to do that. Great. So it looks like we have quite a spread of different people. It looks like 11% are healthcare providers, 6% shelter providers, 23% homeless service providers, a couple legal advisors, some policy advocates, some students, and others. So welcome everybody. So now we'll get started with reintroducing our panel. Our first panelist is Scott Atwater, who I've had the pleasure to work with over the last 15 or plus years with our work at the Living Room and other shelters throughout the Bronx. Scott is the Assistant Executive Director of Bronx Works. His portfolio includes doing work with the street homeless services. Like George had mentioned, he is a tremendous advocate for our homeless individuals. He does work with family shelters, HIV/AIDS services, and foster care prevention programs through Bronx Works. Scott's created the Bronx Homeless Outreach Team, which oversaw the homeless service arena and has been widely recognized as being a leader in engaging with our street homeless individuals and getting them housed. So it's a pleasure to have you, Scott, as part of our panel. Our next panelist is Cassie Burke. Cassie is the Program Director for Breaking Grounds, Street to Home, and Williamsbridge Stabilization Bed Programs. She oversees a wide range of services for people experiencing homelessness in the borough of Brooklyn. Cassie's social work practice has focused on people living with HIV and AIDS, people living with severe mental illness, and primarily on people living on the streets and supportive housing. So welcome, Cassie, and it's very nice to have you on our panel. Our next panelist is Douglas Wilkes, who is a consumer at Care for the Homeless and has struggled with addiction for over 20 years and experienced street homelessness for over 8 years. He has been in recovery for 5 years and has been stably housed since 2009. Douglas is with me here today. We are both vaccinated, so we are going the unmasked route today. And he was on another phone, but was having some interference, so we figured we'd just do it together. So welcome, Douglas. Douglas has been one of my patients for the last 5 years and has been successfully housed since 2019. Douglas is also a gifted songwriter and plays guitar and piano. And he has told me when I just asked him to describe what he does, that he is a street therapist. He does do his performances on the street, and with his performances, he tries to help people with being homeless and getting back into recovery.
If they understand what I'm trying to do.
Yeah. Always a work in progress, as always. And our final panelist is Dr. Van Yu. Dr. Yu is the Chief Medical Officer at Janian Medical Care Center for Urban and Community Services. Prior to joining the Project for Psychiatric Outreach to the Homeless in the spring of 2003, he was an attending psychiatrist and also Assistant Director of Bellevue Hospital Center for Comprehensive Psychiatric Emergency Program. So welcome, Dr. Yu, as well. And we have worked together and crossed paths many throughout the year, so it's really nice to have you on our panel as well. So I thought we would start off with everyone just kind of describing a little bit of what they do and how this has changed over the last year with COVID in terms of meeting the health needs of our street homeless New Yorkers. And if you've noticed any trends throughout this past year or things that you find most pressing. I thought we would start with Scott.
Thank you. Thank you for the kind words as well. You know, first of all, I would like to just acknowledge our long-standing relationship with Care for the Homeless and with Janian. We have had a partnership with both organizations that stretches back, I think with Care for the Homeless, more than 30 years, and with Janian probably more than 20 years. And, you know, for me, it's just evidence that we don't need to be all things to all people. You know, partnerships are important. We do what we do. We're a community-based organization, and there are lots of really good organizations out there that make really excellent partners. So with that said, you know, I think this last year has been extremely challenging for people who are on the street. You know, we looked at the numbers. The number of homeless people a year ago in April, the number of homeless people that died was roughly double over what would be normally expected. And so I don't think it comes as any surprise to any of us that COVID really hit, our clients and the folks that we work with especially hard. I think the same thing is probably true of people in our supportive housing programs. It's had a hugely negative impact on people and people's health. I think we all know that our clients tend to be frail to begin with. And, when this pandemic is actually hit them extra hard. I mean, there are lots of struggles with doing street outreach. When in the height of the pandemic, just getting two people to go out in a vehicle together was challenging. Making sure that we could get PPE for our staff that couldn't work remotely was challenging. After all, this work is not work that can be done by and large, from offices. It needs to be done on the street. So with that said, it has been an incredibly challenging year. There's been some positive things too. The city did increase the number of stabilization beds. And we were probably able to get more people off the street over the last 12 months than what we ever have before. Our hope, the annual count of street homeless people was down significantly across the city. It was down in the Bronx. So, this increase in the number of low threshold beds that were made available to people, that is something that had a really, positive impact despite all the challenges. So thank you.
Thanks, Scott. That's what you mentioned is very true. And I think we did have a lot of challenges. I think, especially with street medicine, there's no telemedicine, right? You can't, most of our clients on the street, all of our clients on the street don't have phones, or if they do, they don't have as minutes or service. So we really do have to physically go out to them. And it's been a great partnership to be able to do that, having the outreach team bring us out. So that's been great collaboration. I thought we'd go to Cassie next, if you can describe what you do and how that's been challenged over this past year.
Hello, everybody. I am the program director that oversees homeless outreach for Brooklyn through Breaking Ground. We're, as with the other homeless outreach programs, we're a 24/7 operation, and you're trying to get to really anybody who is living on the street and provide them with the services they need to get inside in most cases, but also just to live safely on the street if they choose to stay on the street. For us, the difficulty was, as Scott said, just getting buy-in from our staff that it was actually safe for them to be on the street. We have, obviously had a lot of staff, people that were impacted by COVID themselves. Either they themselves became ill, or they had family members or close allies who became ill, and so they get a lot of people in and out of the office and able to work different ways. Obviously, childcare was a very big issue for our staff with the schools shutting down, and so a lot of our staff are parents, a lot of them single parents, and so that was a really difficult line for them to be able to continue working and serving our population, which they're very dedicated to, but also dedicating themselves to their families and to making sure their children were going to school, which is so important. And as far as street medicine goes, our street medicine team is part of Janian, and they were absolutely incredible. Each of them, they had a few different times where one of them got ill, or they were exposed to someone who was ill and they ended up having to quarantine. That happened a few times in the process of the spring and summer. But they were, so diligent, and they were so present for our clients and for us to, go to them and ask questions whenever we had somebody on our team who had been exposed or who was infected. I myself had COVID, and I really was able to rely on them for help, like kind of transmitting messages to my staff and helping us to navigate just any issues that came up, or any questions we had, or even any fears we had, to manage, the day-to-day work of our staff in such a really incredibly stressful time. And for our clients, it was really just making sure that they were safe. encouraging folks to go into shelter was really obviously very difficult and not really something that we did a lot of during the early days, because it wasn't necessarily safe and people didn't feel safe. Even if it was safe, people didn't really feel safe. And so, you know, we kind of managing folks on the street, managing their fears and anxieties and expectations. And then with the bringing on of all of the stabilization beds that DHS brought on, it was very impactful to our population, giving people just a room to stay in most cases. In other cases, like the program that I was overseeing in Williamsburg, we have, you know, case management on site and meals on site and everything else. And so allowing people to come in to a very low threshold space and feel safe and feel comfortable was super, super important.
Great. Yes, thank you, Cassie, for sharing the challenges both of the staff and of the clients. I know it was challenging for everyone, and it sounds like you were able to recover and then from your COVID, and that's great that you're back and working. So thank you for all you're doing in Brooklyn. We'll move to Douglas next, who will just tell us a little bit about his experience. Douglas has been housed over the past year, 2 years actually, right, Douglas? And so he will kind of just talk to you a little bit about his experience on the street and kind of now that he has been housed.
Well, my experience on the street was really difficult because the baddest part was the cold weather. A lot of people that are homeless can get away with the summertime because you can always go sleep somewhere. The cold was the worst part. As far as the drug addiction, that helped me be homeless because as long as I was high, I really didn't care too much. Again, when I turned to face and looked at myself when I got to the shelter system, me as a strong individual, anyway, I used it as a stepping stone. What I did was use it to rehabilitate myself, which can be difficult because not everybody's that strong. I saw a lot of things I wouldn't want to see in shelter systems. I lost a couple of friends I met from being in the homeless shelters who overdosed in their rooms due to self-medicating. So basically, I'm proud of what I did, and whatever I can do to help, I'm here to talk about it. I hope I passed your audition.
No audition needed, Douglas. Thank you for sharing.
It's true.
Thanks. And now we'll go to Dr. Yu, who will tell us a little bit about his work in Manhattan and what they've been challenged with over the past year.
Thanks, and thanks for having me. So I'm with the Center for Urban Community Services and with its healthcare affiliate, Janney Medical Care. And Janney Medical Care provides psychiatric and primary medical services and nursing services where people with lived experience of homelessness get other services. So like at shelters and supportive housing sites and drop-in centers. But for this conversation, the relevant activity that we do is that we provide street medicine to the Manhattan Irish Consortium and to Breaking Ground Street to Home, including Casey's operation in Brooklyn and also their Queens operation. And we provide psychiatry for the Manhattan Irish Consortium, Street to Home in Brooklyn and Queens, and to Scott's operation in Bronxworks. And in that, and there we partner with Dr. Littleton's operation, her street medicine operation. I'll say one sentence about why this even all happens, that it was recognized back probably in the 80s that a significant portion of people who are living outside who could benefit from healthcare services, psychiatric and medical services, face many obstacles to accessing those services at brick and mortar clinics or health centers, even places like Care for the Homeless that are set up for them. That probably something like 20% of people don't access services that way. So you have to really bring services to them. So that's why operations like Janney Medical Care exist. So over the course of the pandemic, I actually pulled our encounter numbers for the year starting March 2019, ending February 2020, and the same period the year after. And almost to the encounter, we had the same number. So in 2019 to 2020, we had 3,216 encounters on our street teams. And the next year we had 3,213, so only a difference of 3 people. So that's to say we managed to keep the operation going at the same rate, right? Which I was surprised to find, especially that was like almost to the encounter. However, the nature of the operation did change significantly. Prior to March of 2020, we had never done even a single phone or video visit. We were part of our philosophy is to go see people in person, right? But especially the psychiatry team pivoted to a much more virtual presence, mostly to protect people from us, right? Not the other way around, although that was also part of it, that your average Janian psychiatrist will serve 3 or 4 different programs over the course of a week. You can imagine if one of those people got COVID, they could spread it to 3 or 4 programs. So we kept the psychiatrist away from our clients to protect them. In any case, over the course of the year, we went from 0 phone visits for psychiatry to 1,001 in the next year. And we went from 0 video visits to 436. The lion's share of those with BronxWorks, because BronxWorks was the team that was really on top of getting the video thing to work for their teams. And then on the primary care, so on the street medicine side, we mostly stayed in person, although we did 134 phone visits and 32 video visits. And I will say this, going back to the issue of, the shout out to BronxWorks for really working hard to get the video operation going. That's actually just an extension of our work with all of the teams, BronxWorks, Breaking Ground, Street to Home, and the Manhattan Outreach Consortium, that the only reason this all works is because psychiatry, primary care, and the social service teams work in a really integrated fashion. If you just plop one of those elements out on the street, nothing happens, right? Because all the good and all the services come out of ongoing engagements with people. Those engagements typically start with the street outreach worker, and then those people introduce our clients to the psychiatrist and the street medicine person. And it's through those relationships that the good stuff happens, right? I can't just walk up to someone in Tompkins Square Park and say, hey, I can offer you treatment. They just tell me to go away, basically, although usually in more colorful language than that. And I'll say one more thing, then I'll stop. I'm imagining we'll come around to this again later in the panel. But something we've never done before is give COVID vaccines. So starting about March of this year, we became a vaccination operation, something we had done some Hep A vaccinating before that, but nothing like the scale we've done with COVID vaccines. I'll give you a little preview. We've given 275 Johnson & Johnson vaccines, more than half of those since the pause ended, which I'm a little surprised by, happily surprised by that. But I'll stop there. I imagine we'll talk more about that later.
Yes, we will definitely highlight on getting the vaccine out. Thank you, Dr. Yu, for that overview. And I think it's true. I think the partnerships is really important to the connection to our street homeless individuals. And I was interested that you were able to get so many televisits. And usually the clients don't have phones. So I'm assuming, and I know the outreach was usually bringing them inside, right? So they were connecting. You want to explain that a little bit more?
Yes, thank you. Thank you for mentioning that. Although a lot of our clients have phones, right? So the telephone visits are much easier to do because people have phones. People don't have like necessarily smartphones or iPads or things like that. So many of those video visits for all the teams, where they were the devices of the teams, not the clients' devices. So the teams themselves had access to devices, and it was the teams bringing the devices to the clients and then connecting to us. And I have to say, one of the things we've discovered that's good from that experience that I think we'll keep doing even after we don't sort of need to, in a way, is that we feel like we were able to reach some people more than we would otherwise, even pre-pandemic, right? That if I'm like a psychiatrist or a primary care provider trying to find somebody and I go to Tompkins Square Park and they're not on the bench where I look for them, then that's like a whole visit that I've spent time not providing care to somebody. But the team in Tompkins Square Park can put someone on the iPad, and then the team in Washington Square Park 10 minutes later can do the same thing with a different person. Then the team with, in Madison Square Park can do the same thing 10 minutes after that. So there's this like efficiency, if you can manage it, that was a nice surprise to find, and allows us to reach people in this like efficient way that we weren't able to before. So we're gonna keep some of that going, I think, afterwards.
Yeah, no, I agree. I think that definitely telemedicine and the ability to connect with people in multiple ways has really helped enhance our ability to reach our population. And I think that there are elements, obviously, of an in-person connection, but there are elements of being able to be able to connect, period, right? And so I think being able to use all of the tools to be able to connect to people will be something I think we all will kind of continue in the future to provide better care. Great. Well, thank you for that overview, Dr. Yu. And so I thought we could talk a little bit about the discussion of some of the successful programs and interventions that you have done. Dr. Yu, you mentioned some of them, I think, with being able to use the telemedicine. And but I thought that maybe everyone could just highlight some of their successes in their programs and some of the interventions that they felt like really worked with the street homeless population and what some of those challenges were. I guess we could start with Scott and then go through to Cassie and Dr.
Well, thank you again. I think actually one of the most successful things we've done over the last couple of years is the program that Dr. Littleton's involved with, and that is getting medical assisted treatment out to people with opioid use disorders. So that's an example of a real team effort. So our outreach staff are combing the streets 24 hours a day, 7 days a week. And we have a pretty good idea of, which of our clients have these really out of control opiate use disorders. And so what we've done is we've steered Dr. Littleton to these individuals and try to get people started on, medical assisted treatment. And, I'm sure Dr. Littleton can give you more exact numbers, but, last I checked, there were well over 100 people who were started on that. And of those 100 people, at least 30 of them ended up accepting a stabilization bed or a safe haven bed. So it's another tool in the tool chest. It's been something that's been really helpful, and I think it's proven that it really helps some people get off the street. Now, this is a program that Bronxworks isn't funded for. This is the grant is actually held by Care for the Homeless, but it is something where it's all in, where we all have to work really closely together to figure out how to approach people, to get feedback, from the medical provider on who needs a bed, to make sure that the message is being sent consistently that, there are beds out there for people who are in this situation, and to be really flexible about who we move in.
Great, Scott. Yes, thank you for that overview. You're correct in those numbers, and we have been able to successfully house a lot of our street homeless population in using engagement for their treatment for their opiate use disorder has been a great engagement tool for a lot of our clients who were resistant to coming in, because most of them really were kind of driving their day and their priorities to their drug use. And so once we were able to stabilize that, a lot of them were more willing to come in and engage with their housing and the rest of their work. So that's really been a very successful collaboration intervention. So thank you for going over that. I thought we'd go to Cassie, if you want to talk about some successful program that you all have done in Brooklyn.
In general, the street medicine program, I believe, has been very successful in Brooklyn. As sure everyone knows, the homeless population shifts kind of as the population of the borough shifts. And so in Brooklyn, as gentrification has kind of encroached on more neighborhoods, our population has really changed, and the issues they're facing has changed. We have, a lot more substance use, a lot more opioid use specifically in Brooklyn, and with that comes, the need for MAT type programs. Our street medicine team, helps people get onto Suboxone in a lot of cases, which is something that it's fairly low maintenance, but it does provide them with some sort of intervention to curb their opioid use. We've also been able to provide testing for hepatitis C, treatment for hepatitis C, testing for Hep A, and vaccinations for all of the different hepatitises, as well as HIV treatment, the testing and treatment for some folks on the street. Sadly, those are things that come along with increased opioid use in our borough. And I think that the beauty of street med has always been just that. I'm sorry for the sirens. Brooklyn is loud today. The beauty of street med has always been that they're very adaptable to whatever we need, and that we've seen that definitely during COVID, but also well before, where if we have a client who is on the street and their need is acute, we can really immobilize our street med team to go out there and find the person and to spend a day with them if they need to, and to be really adaptable. Or if it's a person that hasn't been interested in services at all, but suddenly is, we can get them out there. Or a person that's not interested in services at all, but has spoken to us about their concerns about their medical condition, and we feel like that might be a good engagement tool with that person. We can use street medicine for that. And they've always been so open to adjusting their priorities and adjusting their schedule, and collaborating just intensely with our clinical staff, but also just our frontline workers, and kind of respecting their input and their insight into our client population and into the specific clients that they're trying to reach. So I think the outreach always has been a thing that you have to be creative, I think, to be successful, and you have to be adaptable to be successful. And street med has always been part of that model, just being really thoughtful in the way that they approach people, really kind in the way they approach people, and really patient-centered in a way that a lot of medical care is not for folks who are experiencing homelessness. And so I feel like that has always been, and this kind of the extension of street medicine and the psychiatric services provided to us by Janie, and it's the same thing. They're really open to kind of understanding that people, they know themselves, they know the medications they've been on them before that have worked and haven't worked, they know the interventions they've tried before as far as their substance use or their psychiatric illness that haven't worked or have worked in the past. And I think the willingness of the street medicine and street psych teams to collaborate with the clients on their own care is profound, and not something we find in a lot of medical institutions.
Yeah, I couldn't agree more, Cassie. I think you said that very well, and kind of meeting the patient where they're at, and really taking a harm reduction approach, and really trying to see what the person is interested in at that time, right? Because sometimes they're not interested in coming in, sometimes they're not interested in treatment for their opioid use, sometimes they're not interested in medications for their mental illness. But when you keep engaging with clients, and they'll let you know. And when you can help them with what they need, then they're more willing to look at other things when that's more stable in their life, right? So I think that's a great approach that you guys have out there. And it sounds like a wonderful program, and you're really trying to meet all of their medical needs when they're ready for that. So that's wonderful. Thank you. Dr. Yu, if you want to tell us a little bit about you, I know you did it already, but a little bit about maybe one of your most successful programs, kind of highlight on.
Sure. I'm going to actually start by picking up on what Casey was talking about, and that'll lead me to a couple of things where we feel good about the last year, which is that, I mentioned before that one of the reasons an entity like Janian exists is that people really have trouble accessing care in sort of health centers and brick and mortar places, right? But it's not just access. It's not simply like I show up at the park and then good things happen. It's, as I mentioned before, it's got to be in collaboration with the team that's already done a lot of work to engage people. And also this recognition that Casey, I think, described really well of, we all have to be flexible with people, right? That, a person who's spending most of their time in the park, isn't going to follow my schedule. Like it's not like I can give them a 10 o'clock appointment on Tuesday and expect them to just show up and be ready to, do my bidding, like that sort of thing. It's as Casey described, right? When John wakes up at 3 PM and says, okay, I'm ready for Suboxone, like we got to figure out a way to like get him Suboxone, like maybe at 3:30, right, on Tuesday, like that sort of thing. So we're always working with the teams, with Bronx Works, with Manhattan Outreach Consortium, to like figure out creative ways to be flexible. And it's not like you can figure out one thing and then apply it everywhere. It's often like you figure out this thing for John and this thing for Lucy and this thing for somebody else, right? And by the way, to hint at something we might talk about later, so we end up attracting the kind of provider who likes that, who likes being flexible and is really good at it. So out of that ability and desire to be flexible and to work really in concert with the social service teams we work at, something Scott mentioned earlier is something we're really proud about, is that we've been able to, over the last couple of years, especially, increase access to MAT, to medication-assisted treatment, especially Suboxone in the last year or so. And that's in concert with this, I believe it's a state, maybe it's also the feds, relaxing some regulations about Suboxone, about who can give Suboxone, about the settings you can give it. Basically, now you can give it anywhere, and about the way you induce people onto it, right? So I don't have numbers, not like you guys have, but we've been able to offer things like Suboxone, naltrexone, Vivitrol, things like that to people who, as they're living outside. So that's one thing we've been very proud of the last year and a half, 2 years. And then the other thing is that what I mentioned is the challenge of bringing COVID vaccines to people. And we're very proud that we've been able to give as many as we have, where I'm actually a little surprised it's been that successful. And that's gone about the way I expected. That some people right off the bat were like, yeah, give me that COVID vaccine. So there was some cohort of people who was very easy. We just showed up and said, we have a COVID vaccine. It's like, yeah, we'll take it. But as you can imagine, there's also a cohort of people who were more, I'll use the word ambivalent, right? For the variety of reasons people have been. And mostly the people who have ended up accepting vaccines for us, I'd say are mostly people who either already knew us or our social service partners had been working with them and engaging them around that and other things already, right? In other words, it doesn't come out of nowhere, right? It comes out of, like, as I said earlier, it comes out of an ongoing engagement, of a relationship that's already a good, effective relationship. And that's where I think most of the vaccines have come from for people who are living outside. And so this last 3 or 4 months of like getting vaccines into arms is the fruit of work that had been laid down for months and months and months for some of these people. And it's just, and I have to say, I'm unfortunately, because of my job now, I'm not the one putting needles in arms, and I wish I was, but I have to tell you, the street medicine people, they tell me it feels so good, because right, you're literally, some number of those shots are literally saving those people's lives. Of course, you can never know which particular person, but some number of them are, right? And it's, it's one of the, I don't want to overstate this, but it's one of the few times where you're doing something, you're like, no, this is actually going to definitely make a difference, right? Even if I can't see it today. So it's felt really good to us.
Yeah, I agree, Dr. Hewitt. Definitely one of the more helpful and rewarding parts of our job, and being able to help in a truly helpful way of giving vaccines out is wonderful. I will get back to vaccine. I wanted to ask you both, Scott and Cassie, about your vaccine rollout and how that has been going. But I did want to ask Douglas about some successes he's had this past year. He normally does street music, and this year has not been able to do that with COVID, but he had some creative ways online to connect to people. Do you want to share a little bit about that?
I'm a musician on a quarantine concert worldwide, and the songs that I write are all in reference to drug addiction. So there's a message. Of course, music has a message like anything else. So as a musician, that's what I do. I try to put with the opioid crisis we all know we're having, and me being an ex-heroin addict who understands it more than a lot of people can, I think the lyrics I'm writing are very good. They will get through partially to people. It's kind of like Scared Straight, if you remember that, with all the convicts that scared the young kids not go to jail. Well, I kind of do it like a horror story, but it's all brutal truth. So it gives, I get fulfilled by it if they understand what I'm trying to do. Other than that, I go into the parks and I try to talk to some of these people. And you're right about how, I think he said that, I'm sorry, I forget their names.
No worries.
The approach, how to approach these people. You have to really approach them with empathy a little bit, with an understanding. And it's pretty hard. Again, the words are going to be more colorful. You know, if they're ready to bite you like a dog. But some of them, you can see in their eyes, they really want the help. But I got to be honest again, you really have to want to help yourself. And I said this priorly to somebody, I forgot last, I'm bad with names. I don't have any empathy toward people who thrive on another person's sympathy. In other words, just giving you a sorry story, such as the people who sit on corners, I need somewhere to eat, I got, you know, it's all a crap story because you don't starve in New York City. I have no empathy on a person who just sits there with a sign to get high. But anybody with a brain knows. But of course, there's always going to be the person that it makes them feel good to give them money. I've seen some of these street junkies have more money than me, and I'm trying to make $1 performing music. And they're pulling out money, and I'm like, what's wrong with this picture? My point given is some of them actually, they like where they are. So it's really in your job, it must be very difficult because some people don't really want the help. Me is just going out and doing this in parks just to do it, to try to give a little insight. I feel like a grandfather, but I try. Some of them really don't want it. They don't care, but some of them do. Like there was a young woman I met, resorted to prostitution. Hey, listen, that's an old story because people will do anything for drugs. I believe she wants help, but at the same time, she's buying drugs, you know, so, you know, who are you playing? You're basically playing yourself. What I did was, again, I'm talking about me. I faced myself to look at me and to know I'm a better person and I can do better. And I didn't want to fail my mother and father, God rest, or my old friends from the neighborhood. So that's up to the person. So again, your job is very difficult.
Douglas, you're housed now. How do you feel like being housed during COVID has been?
I'm fine. I'm fine. But, you know, I get lonely at times like everybody else, but it's better than being in a shelter system. But the shelter system wasn't so bad if you go with it. There's nothing, but if it's counterproductive, it's like you have to stay away from the wrong element. And you really have to do it yourself.
It can be hard, right?
It's definitely, I told the guy, I said, you kick a heroin problem. I wrote it down in lyrics. It's easy to get to the entrance, but try to get to the exit because there's a maze. It's like to get in this addiction is very simple. Just be dumb enough to do it and be smart enough to get out. But to get out of it, now you've got people who take Suboxone and they don't really want to take it. They want to sell it for drugs. Or then you have the Band-Aid effect, I called it. I would do my heroin, go to work as a laborer. And if I didn't have my heroin, I did Suboxone. Now, the needle and spoon thing, now here's the vampire disorder, I call it, because this whole hype of putting that drug in a spoon, running with your friend to go get the drug, even if you don't get high, you did it though. So 50% of it is actually a ritual so the cycle, now you've got the mental, like when I was on methadone, the counselor would be like, your urine's dirty, I have to raise your methadone. I said, you can raise me to 1,000 milligrams, but I can't break the psychological. So that psychological, back when I first got into heroin, I was sniffing heroin. And my friends used to tell me, watch this, I did it. If you do it every 2 days and leave it alone for 5 days, you don't get hooked. And I did that. I tried to manage it. I thought I was in control. Then I asked him, how can I shoot? My old friend, God rest, said, I'm not showing you how to do that. Another friend of mine told me, when you get into that needle and spoon, now you're in a whole different atmosphere. There's a song by Heavy Cream, Eric Clapton, called That Spoonful. That's what the song is about.
Thank you for sharing, Douglas. Yeah, it has been, I'm sure, a struggle. And
it's a struggle every day.
Yeah.
But struggle for the better. Me to get out of bed to come help Dr. Littleton, who I have a good rapport with, I'm more than happy to do it. You couldn't pay me all the money in the world. I'm more happy to share what I can share as world-round experience, not to insult anybody's intelligence, but reading about it, but living through it are two different things. It's kind of like serving in the military. I heard about getting shot. You heard about it, but did it happen?
Yeah.
So,
yeah.
And again, that's a hard job. In the future, I would love to do some kind of work with outreach myself.
Yeah.
I would, if anybody can help me, I'd be more than glad to do it.
We'll work on it.
Because I really know how to get to some of these people. But again, some of them are just psychic vampires. They just want you to feel bad for them. But you see, that's a no-no. I'm only going to feel bad for you so long. It's like my father, God rest his soul, who was in the military, a Korean War veteran. Hey, I didn't tell you to do this.
Well,
that's about it.
Yeah, thank you for sharing, Douglas. And we'll definitely take you up on working for us, right, Scott? We'll find him a spot for sure.
I think I could be very helpful.
Definitely. And the substance use counselor that I work with actually had been homeless himself and had been a heroin user himself in the past. And so I find that lived experience, like you mentioned, Douglas, is really helpful for us to connect with our clients and engage with them and really help them understand that we do know what they're going through, and we're going to try to help them in the process.
I'm sure you do.
So I see it's 11:50 now. I did want to just ask Scott and Cassie briefly to talk about their COVID vaccine initiatives and how successful that had been, and then we'll go to some of the questions. I see there's a few questions that people put up.
It's interesting when the vaccine first became available. I heard lots of people say, we'll never get our clients to take the vaccine. This is a vaccine resistant population, and so on and so forth. And fortunately, we haven't found that to be true at all. And just not speaking specifically about our street outreach program, but I know that we had one event in our men's shelter, and about a quarter of the people in the shelter showed up for the vaccine. So we've been really pleasantly surprised at how people have responded, and it'll be interesting. One of the things that I'm looking forward to seeing is that for people who work with us, and we work very closely with the Bronx Information Organization, the Bronx Health Information Organization. We're a partner organization. So what that means is, and it's up to each individual client, but if they agree to sign a release so that we can get some of their health information, we can get access to the records and so on. So in the next week or so, we'll be getting reports for all of our clients who signed the consent and allow us access to the Bronx Regional Health Organization. We'll get a report per site as to exactly who's taken the vaccine, who isn't, who hasn't. And we think that that's probably going to be very helpful data. And we can leave people alone who've already gotten it, and we'll be able to focus on people who haven't gotten it and talk to them about their options and about the different vaccines. One of the things that has been a problem is that a lot of our employees have been loath to get the vaccine. And I think there's, lots of reasons for that. I think you see that throughout the country. On National Public Radio this morning, I heard a report that in Iowa, less than 50% of the population has been vaccinated for various reasons. I would bet that our population, well over half of them have been vaccinated, but it'll be interesting to see. We've gotten as much resistance from employees as what I think we have from clients.
Yeah, that's very interesting, Scott, and I would agree. Some of the other factors that go into some of the people's rationale on the vaccine. Cassie, what have you guys seen in Brooklyn in terms of getting out the vaccine?
Most of our vaccine efforts on the street have been through Janian, and as always, they've been very, very dedicated to kind of finding a way. Even before Johnson & Johnson was approved, they're finding a way to get the vaccines that have to be very, very refrigerated and very, very closely watched out to our clients. Obviously, they couldn't do as many because the Moderna was much less stable, but they still, did a great job of getting people out there. I think, for me personally, I spent the first few months of the year just kind of poking at DHS, trying to get them to give, to help us get vaccines to folks, because we did have clients who wanted it. Especially I was working in a stabilization bed program as well. And, a lot of those people, we had one weekend in January where we had 12 positive cases, and we had to, in addition to getting those people into isolation, we had to then quarantine another 25 people. And, that is incredibly traumatic for people being kind of pulled from this place where they're comfortable and they feel safe into a hotel. It's a nice hotel. They had a kind of luxurious stay once they got over it, but just the action of being forced to go somewhere else is really traumatic for people. And so kind of my efforts to get the vaccine into our spaces was in part because we saw just how frightening it was when someone would test positive, and how difficult it was for people when they were made to go into isolation. And so we've been really glad to have both Janian and now DHS coming in and doing those vaccinations. We have a monthly testing and vaccine clinic that DHS brings to us at the stabilization bed program every month. It's tomorrow if people are interested in vaccines. And we don't have as many people as we did at the beginning who want them. For the most part, the people that wanted a vaccine have gotten it at this point. But the fact that we bring it in and we have an opportunity for folks to get it, if they've changed their mind, or if someone has convinced them, or if they're enticed by the incentives. We got an offer the other day, which we weren't able to take because it was too short notice, for Brooklyn Nets tickets, and you have to be vaccinated to receive those tickets. There's been some smaller things like a free donut or a free, I think, thing of fries at Shake Shack, like different things like that. Sometimes people are induced by those freebies. So I think there are still some people who will receive it, and I think until there's a shot in every arm, we keep trying to convince folks that it's worthwhile, and using our own stories of being vaccinated and getting through the period of side effects and all that other stuff is important.
Yeah, no, I couldn't agree more. I think in some of those little incentives do make a big difference, and I agree. DHS has been very helpful for us too with Care for the Homeless in terms of providing us and helping us get out the vaccine. And telling stories is really helpful for a lot of our clients, because there is a lot of distrust, like Scott mentioned, and some disbelief and conspiracy theories and things like that out there. So really having the trust and affirmation of the providers that they see and work with and trust is really important to getting the vaccine out as well. Great. Well, thank you all so much. There's a couple questions I just wanted to try to touch on. Someone asked one kind of in the beginning about finance delivery. How does one finance delivery of clinical services on the street or a mobile unit? Is this a grant funded work? And do we bill insurance? I can certainly say for the Care for the Homeless Bronx Works piece of it, we do bill insurance if they have it in terms of Medicaid, but we do have some grant funds that also help the work that we do. So I don't know if Dr. Yu and Cassie, you want to comment on how you provide the services that you do.
A lot of the services on the street provided by us for psychiatry and primary care are Department of Homeless Services contract dollars. So, for example, the Manhattan Irish Consortium gets money in their contract from the city to provide street medicine and psychiatry directly, and that's largely. I mean, I don't want to read people's minds over at the city, but I think one of the reasons that's happening is because the city does recognize all the obstacles there would be to bill for services on the street, right? The person who I'm meeting in the park barely wants to talk to me about their foot, right? They're not going to engage with me in a conversation about their insurance, right? So, that's a non-starter for so many people. And also there's just a lot of sort of insurance regulations that don't even work so well in clinics, but like definitely don't work outside. So the obstacles make it such that you really have to, for us anyway, and it's also the way we're set up legally, I won't get into it. It has to be, at the moment, it has to be funded directly. And again, it's mostly contract dollars.
Cassie, did you want to comment?
Yeah.
The outreach team is the same way. Yeah, all of ours is funded by DHS at this point in time. We have had some grants here and there that enhanced our services. And the insurance part is a huge challenge as far as like trying to get, if someone does need medication aside from what the street medicine teams can provide, that has been a huge challenge and something that we're always working on, trying to find like funding sources for different folks who need meds outside of the kind of standard, antibiotic, pain reliever sort of stuff. But yeah, it is all funded through DHS contract dollars.
Yeah, if I could just add one thing. The good news is DHS actually put a lot of additional dollars into our budget for street medicine and psychiatry. And what Bronx Works does is in turn just, subcontracts with Janie and Care for the Homeless to provide the services. So we're really looking forward to significantly beefing up our ability to provide medical and psychiatric services to street homeless people this coming year.
Great, thank you all so much. I think that we are almost out of time. There was a question to Dr. Yu just about has patients and how they responded to moving to telemedicine. Have they been able to determine which patients do well with it and which prefer visits, and how that transition is working?
It's been very variable. A lot of people like it, really like especially even the phone, right? That for some of our patients, they find it like really convenient, right? And like, oh, instead of having to like travel somewhere to find you, I can just call you, or you call me and I pick up the phone and we can do whatever we need to do. So for the convenience factor, I think a lot of people really like it. Not that they want to 100% replace in-person visits, but I think some of my patients personally are going to be like, yeah, I don't want to come see you. Like, just keep calling me. Right. I think that's going to definitely happen. For some people, it's actually also clinically easier. Right. So people with certain kinds of psychiatric symptoms might find it easier actually to interact over the phone rather than in person. There's like an intensity of in person that's for some people is a little bit anxiety provoking. Right. And then there's some people who it's not as good. Right. That the person that we're working with themselves doesn't feel as connected to us. And then it is more difficult to assess and evaluate what's going on with people if you're not in the room with them, right? Especially as I alluded to earlier, it's like really impossible to do primary care over the phone. Psychiatry's better. But even there, especially if it's somebody you don't know that well, you're meeting for the first time, you do lose a lot by not doing it in person.
Yeah, I would agree. But there is a good balance and sometimes convenience to being
Yes.
able to phone for sure. Great, we're almost out of time. The last question was actually to Douglas. Someone was asking if there's anywhere that they can hear and share your music. Do you have anything
Sure,
online?
you can hear it. You can go to Quarantine Concerts Worldwide and punch in Boost Man. And there's over 45 videos. Or as I got out of the shelter, in the recreation room, that's not my best work, but you can look it up. Go to Doug Weichel, W-Y-K-L-E, 55.com on YouTube, and that'll pop up. That's something I did with the guy that ran recreation. He was an artist, Francis. Before I got out, I wrote a poem about drug addiction, which the co-director said I was being a hypocrite, but if she read the lyrics a little more, I'm not being a hypocrite. I was telling them I was there, and this is where you're going. And the poem is called The Dead Zone. So real quick, I'm going to be egotistical now. It says, outstanding joke, life on dope. The path of life has no meaning. You'll need more and more, isn't that how it seems? Nothing's real, you can't conceal, you're caught up in a rat race with a vampire disorder running through your veins. You're inviting suicide, you're going blind, you're forgetting about your future. And it feels so good, but you're really not so sure. You'll have no money, but you think of somebody as you're walking the street with your head in a dark cloud. You don't even want to put your life together. Tell me, why do you feel so proud? You'll be so damn high, you'll feel so good inside, although you're carving your name on a gravestone. It's easy for you sucker because your head needs stuffing because you really feel so alone. You're in the dead zone.
Wow.
That's it.
Wow, thank you for sharing, Douglas. And you
Sorry about that.
Yeah, no, that was wonderful. No, and you perform live too. Where at Washington Square, or where do you usually?
Well, lately I've been going to Union Square, and it's funny. This gentleman said Tompkins Square. I might go down there. I try to perform songs with messages.
Great, great. Well, thank you so much for being here, Douglas, and sharing. And thank you, Scott, Dr. Yu, and Cassie for being here as well and sharing the great work that you guys are doing. And please keep it up. We are I think making positive changes every day in people's lives, and I thank you for all the work that you're doing. And with that, I guess we'll call it an end. Thank you so much, and we hope to continue this conversation in the future.